In 2011, more than 31,000 Arizona Medicare patients were readmitted to the hospital within 30 days of their discharge. It is estimated that up to 90% of those readmissions may be avoidable. Hospital readmissions are a significant expense that costs Medicare and taxpayers billions of dollars every year, not to mention the toll they take on patients' lives. Readmissions are the result of a fragmented healthcare system. To combat this problem, providers across the healthcare continuum in Arizona have joined forces through the No Place Like Home campaign. This robust 18-month campaign brings together providers from all care settings to reduce avoidable rehospitalizations in Arizona by 20% by June 2013. In this video, we will introduce you to stakeholders working together to improve care for Arizona's patients and their families. But to be effective, we need everyone's expertise and involvement. Join with us as we discover why reducing hospital readmissions and allowing patients to safely recuperate in their homes is simply the right thing to do. Because there really is no place like home.
I think that hospitals do an excellent job in general of providing care for patients. We see so many good things in our hospitals, and especially in Arizona hospitals. However, there are circumstances and times when a person is readmitted to the hospital when things could have been avoided.
The No Place Like Home campaign was started because the readmissions issue is a huge problem, and people are revolving from their homes to the hospitals to other care settings and back to the hospitals.
People with Medicare have about a 20% readmission rate within 30 days. So that means among Medicare beneficiaries who are discharged from the hospital, about 1 in 5 is back in the hospital within 30 days.
As an industry, nationally, they say it's a $25 billion opportunity. On a local level in Arizona, we know that if we reduce readmissions by 20%, we will avert 4,000 readmissions. When a readmission's average cost is $8,000 to $13,000, that adds up to a lot of money. It adds up to about $50,000 to $90,000 a day.
It's become such a complex, fragmented system of healthcare that many things get lost between, in transition, lost between primary care provider and hospital, home and the hospital. There's so many moving parts of this for patients and families, and like I said, it's so complex that we need to find ways to make this understandable for our patients and for the post-acute care providers that they go see, so that we have some continuity.
Multiple transitions of care result not just in doing a potential disservice to the patient when we aren't communicating across those transitions of care, but it also can be a safety issue when those handoffs aren't managed appropriately. So because we're all involved in that continuum of care, we're all ultimately accountable for trying to make this situation better.
What's most important in everything we do, no matter what setting we live in, no matter what setting we work in, what's most important is the patients and the residents and their family. And if their care is fragmented and we aren't communicating well with each other, it puts barriers in the way.
The question is, can we create a system which allows patients to be at home, deliver appropriate health care, utilize the hospital for patients when they get really, really sick, and thus we believe that we'll probably be able to impact some of the cost issues that occur. They're driving healthcare costs to a breakable point at this stage.
What is unique about Arizona is that we have campaigned this through the No Place Like Home campaign. We have called all the hospitals and all the healthcare providers, the skilled nursing facilities, the home health agencies, the community pharmacies, the healthcare, the physician providers and licensed independent practitioners. We've called them all together and we've said, listen, let's work on this together.
This is an issue that the hospitals themselves cannot solve by themselves. Even if they improve their own internal processes, including better and more effective discharge planning processes, they still have to work with the downstream providers who they discharge the patients to.
What you need to do is have an effective method to discharge your patient. And by that I mean is there needs to be a very well laid out plan, usually involving not just the physicians in the hospital and the nursing staff, but also case management, so that when a patient leaves the hospital, not only the patient but the caregiver who's taking care of that patient knows what's expected and what should be done in order for the patient to have the proper care once they leave.
Maybe they've created a great solution for certain challenges, whether it's medicine reconciliation or how to follow up with patients. I think all of us are able to focus our energies a lot more effectively without reinventing the wheel if we share those successes.
And truly the answers are all in the room. We all just need to share what we feel is working in our own settings so that we can learn from each other.
The goals of the No Place Like Home campaign are aggressive. We aim to prevent 4,000 patient readmissions within 30 days of their hospital discharge by June 30th, 2013, reduce the overall readmission rate for Medicare beneficiaries by 20%, and decrease healthcare expenditures related to hospital readmissions.
Nationally, the Partnerships for Patients campaign has stated that the goal for reducing readmissions is 20% reduction by 2013. And so the No Place Like Home campaign has adopted those principles for Arizona, and it's achievable because the research has shown that by implementing programs and evidence-based interventions to reducing readmissions across a number of different care providers, that 20% reduction is achievable. That's something that we can do.
It's important that all players in this work together, all the stakeholders work together, because patients' care is not isolated. It's a team sport.
The No Place Like Home campaign fits solidly into three broad aims of the National Quality Strategy: better healthcare for individuals, better health for populations, and reducing costs.
If you think about it, what it really means is that if you deliver the highest quality care to a patient, you will avoid all these issues that we've been speaking about, readmissions as an example. Good quality care means you have lower readmissions and then you have a lower cost. Good quality care also means that you're going to have the best possible care for the individual, and if the individual is healthier, then the population in general becomes healthier. So the triple aim really ties everything together.
In addition to the savings that we know that we can have just from averted readmissions, another pressure point that hospitals are facing is that they are now going to experience financial penalties for patients who are readmitted with certain diagnoses. Starting this October, they will be having a 1% impact on their financial reimbursement for patients who are readmitted with the diagnosis of AMI, congestive heart failure, and pneumonia. That 1% will increase next year to 2%, and it will spread from those three diagnoses of AMI, CHF, and pneumonia to all cause. And in the following year, in 2015, it goes up to 3%. So it has a huge financial impact not only on the money saved with readmissions, but on the money lost.
But who's going to complain about solving a readmission issue? As a doctor, I don't want the patients back in the hospital within 30 days. Hospitals don't want them back. Hospitals are running at capacity. Insurance companies don't want them back. They have to pay more money. So you're not going to find a stakeholder that feels that readmissions is a good thing and we ought to protect it.
The No Place Like Home campaign may be ambitious. However, the consequences of the status quo are overwhelming, not just to the bottom line, but to patients and their families as well.
When you look at that from a patient's standpoint or from a family standpoint, they've spent 3 days, 4 days in the hospital, and now within a short period of time, they're needing to come back into the hospital, and arguably for reasons that are largely preventable.
They go home and now they have to be readmitted. It's not just medically deflating, but it's also personally deflating. They feel that they failed themselves. They feel that they're unable to care for themselves. They feel that they've lost control. And face it, nobody likes to feel that they've lost control over their own way of living, their own lifestyle.
The initiative also allows us to focus on the outpatient settings because people really don't want to be in a hospital. They want to be in an outpatient setting, much like their home, for that delivery of care and services. From a personal perspective, I am now getting to an age that I'm looking at my health outcomes, and I would much rather find myself in my home getting my care in a community manner than in the hospital setting.
This to me is a public health issue. In the same way we developed vaccination to get rid of smallpox, getting rid of readmission problems and driving a safer healthcare system that becomes cost effective is the right direction for us to move in.
We all went into this because we want to take great care of patients. And the great way of taking care of patients is to make sure they have the best outcome possible, and not only the best, but the safest.
No Place Like Home is the right thing to do because it focuses on all the essential elements of proper care. We're talking about proper handoffs. We're talking about communication and collaboration between care providers. What's not to like about that model?
There's a critical mass of energy, and the No Place Like Home initiative here is a wonderful collaboration of very key stakeholders, and the very fact that they have come together and set this very specific aim, I think is very promising.
This will truly assist our patients and our community. And it's going to be very far-reaching for us, and I'm very excited about that. The benefits of this 2 or 3 years down the road, I think we'll be talking about this then and going, wow, what a great thing that we did.
I'm excited about where we're going to be in 18 months. I'm excited to see the results that we achieve from January 2012 to June of 2013. I'm excited to see hospitals collaborating with the SNFs in their community. I'm excited to see healthcare providers no longer having boundaries with each other, but coming together and working on the problems.
The reason why I'm really excited about this project and why I'm involved in it is because ultimately it is really the right thing to do for patient care. It's really making patients feel like we really care about them beyond the walls of the hospital. And I think overall everyone is going to be much happier. The physician's going to be pleased, the patient's going to be pleased, and the family members. And I think staff feel like it's a good thing because now we're doing all the right things for patients out in the community.
Patients will end up with better care. It's that simple. And hopefully they'll end up with better care, less errors, better safety and quality, and manageable healthcare resource utilization usage. Tell me what's wrong with that.
For more information about the No Place Like Home campaign, visit our website at www.noplacelikehomeaz.com.